So good morning, and I'm going to show you something similar on the lines of what Himani has shown, 3 cases. So this was a case where, the patient had -3 power and everything else was fine, and I did with a microkeratome, a BD microkeratome when I used, and just see when the keratome goes back, it's almost as if there's an entire flap that has been created, whereas in reality that is just the epithelium. The question was, what do I do now? Do I proceed or do I not? I decided to take the bit of risk, proceed with the LASIK, because either way, if it heals, it heals. If it doesn't, it doesn't. It's flap related, nothing to do with the LASIK. Look at the amount of epithelium that has come off, almost the entire thing. So what I did was, I cut off all the epithelium, like we know, no loose epithelium. I put on a BCL. Within a week, the patient had 6/9 vision. When I went for the other eye, almost after 3 weeks, I realized the same thing has happened there. Despite all precautions, changing the blade, and once again, look at the loose epithelium. It is almost coming off. So this is again a case of epithelial membrane dystrophy. Nothing else. It's happened in both the eyes, and it happened during surgery. Okay. Excuse me. Okay, the next case is another case where again I used the BD blade. This was a young patient from Mizoram, and fortunately for me, she wanted one eye at a time. So this was the first eye, and just look at that mark on the flap, and I should have been alerted when I was not able to lift up the flap the first time, and the mark persisted on the stroma. However, these were my early cases. I was not very alert. I thought it was okay. I did the surgery in the morning. In the afternoon, she came back with immense pain, and what I find is that for half the flap, there are only strands of epithelium. There is no 90 micron flap there. Half of it is 90 micron, the rest of it is just strands of epithelium. And I didn't know what to do, whether to take off the entire flap or to just cut off that epithelium. I decided to just remove the epithelium, leave half the flap on, put a BCL. It took almost 20 days to recover, but the patient ultimately had a 6/9 vision, though there was a thin haze there. And sorry, this is the first thing that came over. Interestingly, I did this patient again after 3 weeks, the other eye, and I had a similar finding. What I cannot find an explanation for is, why is there the defect only in half the cornea? Why in that particular pattern? I've presented this in many places, and I've not got a satisfactory answer to this. Now the third case is something that is, the first two we had an explanation. It was a microkeratome. The third case is a femtolaser, which we know is very safe. But just look here, the laser part of it went very fine. I had nothing, no incidents. And here I'm trying to lift the flap, which is again, as you can see, it's like passing a knife through hot butter. In the first this thing, I always take three sweeps. The second sweep, it went right through the center of the flap, cut right through the center. That is when I realized that the other part of it had not even been dissected. It was sort of still adherent, and I didn't know what to do, but then I attempted. This is an edited thing. It took me almost 45 minutes first to make up my mind what to do, and then to proceed with it. I somehow, sort of cut and lift, and a very ragged flap I got. I managed to pull it across, decided to proceed with the LASIK. My logic has always been that whether vision will come back, whether you do a LASIK or you don't do a LASIK, because it is flap dependent. So if the flap heals properly, if you do a LASIK, vision will come back. If it does not heal, then even if you don't do a LASIK, the vision will not come back properly. So at the end of it, I have pieces of flaps which I now have to place together like a jigsaw puzzle, trying to fit in all the corners. Took me a lot of time, but I was able to do it, except for this little bit that was rolled up like a cigar, and which took me a lot of time. Ultimately, I was able to put it back into place, and the patient had good vision the very next day. So in this case, what had gone wrong What had gone wrong is that the temperature in my OT had, the AC had stopped functioning in between. I had not realized that the temperature had gone up, which is why the laser had probably not fallen properly, which is why it's very important that we maintain the temperature and the humidity of the room while doing a femtolasic. Thank you so much.
Lovely. I myself don't have the answer for what went wrong.
That's
So,
why I presented it so many times, but I really don't.
but the
have an answer.
videos are very nice. Surprisingly, you did not lose your confidence and managed it. Many
That's
people
because you
would
are
just
seeing the case. You're not seeing me.
yes,
Believe me, my first instinct is to run from the OT, never
exactly.
come
Anybody would want to do
And
that
then
the
I
way
keep-
they have torn out.
back. And I keep telling God, get me through this one, and never again in my life will I
And
do a
then they
LASIK
come back
surgery.
again.
Absolutely.
After 3 months, you had the daring to do it again.
We all have to move on.
Yeah, exactly. And it happened again.
Yeah, it happened again.
Wow.
I think the best part, intact IBD has gone into pieces. It's better to do a surface
But
ablation later
the
on.
second case had a bit of a, I don't attempt surface ablation. That time we were not having the transepithelial thing. So I do not attempt a PRK if it is beyond 5. In fact, I'm
That's-
comfortable doing up till 3.
Or
Even 4,
otherwise,
5,
you
I
can
don't
choose the
like it.
ICL if you feel like.
Yeah.
I mean,
Huh.
it's much safer
Much
than doing,
safer, much safer.
doing cornea touching again.
Because only just think, because if in one eye it happened like that, so ideally you should have just
Expected it in
yeah,
the second
so that
eye,
you
but-
are also at peace. I feel you managed
Honestly
it. That is
speaking,
true.
At that time, we were
but,
not even doing the ICL that
Correct,
regularly. Now, yes, anywhere I see problem, go for the phakic IOL.
correct. Phakic IOLs are the best.
Much
I
safer,
think
much
right
safer.
now.
Second, if you get a problem in first eye, many of the patients have those problems second eye too.
Yes.
So we should be more cautious in doing
Cautious
second
when
eye of
doing
that patient.
I just have a question for you now. With all the problems that we face with laser and with having phakic IOL in the background, why are we still doing corneal procedures? Why are we not completely switching over to phakic IOL?
See, eventually I feel it is going to switch over to ICLs only, phakic IOLs, but then the cost is also a matter, and
think-
the technique. Doctors have to be trained. They are not. Everybody is not yet trained. Many are still trained in LASIK, and eventually things will change. Now the blades and also are going to stop getting manufactured, so you have to stop it. They are I think the companies are
Do you
only
think
stopping
that
that
it is a
microkeratome.
safer procedure, because there is one argument which says that you might just go in for endophthalmitis?
No, not even endophthalmitis. You can go for glaucoma also. You can
Yes.
develop cataract also.
Yes.
So it's not totally complication free.
That is true.
Even if you do best of things, some patient may develop complications. In the cornea, most of the things are manageable.
Correct.
That's
Yeah, but most of the complications are that severe that hamper the vision or that so that's why it make much safer also. So we got a lot of things in your surgical armamentarium. You can choose which one is fit for what. It's not the one procedure that's fit for all. Everybody is not for flap LASIK. Everybody is not fit for ICL. So naturally, or maybe a surface ablation too. So naturally, we have to choose a between. Thank
Okay.
you.
Thank you
you
so
very
much.
much.
Thank you.
Never lift the flap. Most of the complication occurs once we lift a flap. Even if you're better to do it with a femto.
Okay.
Of course, we can do after the procedure also, but in a very demanding patient, the patient you don't think is going to be a 6x6 or going to get hematopia, but still you want to do it, then that's the thing I think can matters there.
Thank you, sir. Thank you so much.